Good afternoon, everyone. Gareth Presch, founder of the World Health Innovation Summit. I am delighted to welcome you to our Road to COP session today. It's a virtual session. We'll be hearing from international experts from all over the world. We'll have a particular focus on Africa for this session. We'll be covering mainly climate and health, and we'll be looking at the intersections between climate, health, financing, the environment. And I think it's an opportunity for us also to look at new ways of modeling healthcare and new ways of financing healthcare. During the session, I'll go through a number of slides here just to set the scene so that people can understand sort of what the agenda will look like. Let's just basically start with why. Climate change is the single biggest health threat that is facing humanity at the moment. And the impacts are just are profound. I think recently we've seen the displacement from flooding in Pakistan, for example. We've seen the drought across Somalia, for example. And we know the effects in terms of environmental factors. We've about 13 million people die every year. What we see as well, which is quite astounding, I was talking to James just previously, 90% of people on the planet are, actually consuming unhealthy levels of air pollution. And the cost to the economy is about 2.9 trillion in economic costs. So it's about 8 billion a day. And this is just astronomical costs, and the human costs are phenomenal. What we're looking at here, and the presentations from my colleagues will look at, is this new way of looking at how we actually bring solutions to the table. And at COP, we hope to showcase this with our partners at the Great Green Wall of Africa. We'll be looking at how we look to preventing disease, and also how do we bring the finance in. So on the left-hand side is basically disease management, and on the right-hand side, which is prevention. That's the new model, very much anchored in around social prescribing. And James from the Global Social Prescribing Alliance will give us an insight into how that model works. Next is called climate change. What is the impact on our own health and well-being? And you've got respiratory illnesses. You've got, we've had, pandemics, and, there's a serious impact of climate change on our health and well-being. And I think we're seeing more incidences, for example, in Acapulco recently in Mexico, devastating. And of course, that puts pressure on our health system, which is already under enough pressure and strain at the moment. Finally, just to say, these are sort of the opportunities, and what we're sort of championing at COP and with my colleagues here, we will be looking at how does the health sector take tangible actions. And what I mean by that is, how do we work with the financial sector and we develop projects that can be financed, and look at our pension funds within the health sector. How can we mobilize 46 million healthcare professionals' pension funds to support ESG and SDG projects? That's sort of an overview. It gives you an insight into the opportunities. And I'm actually going to hand over to the chair of the World Health Innovation Summit at the moment, Dr. Amir Hannan, who will just give us a broad overview from a primary care perspective. Amir, I'm going to hand the session over to yourself, and very much looking forward to your presentation.
Thank you very much. Hopefully you can see that there. And thank you very much, Gareth, for that introduction. So I'm Dr. Amir Hannan. I'm a full-time general practitioner or family physician here in Hyde in Greater Manchester in the UK. And today I'm going to just do a brief presentation around climate change and sustainability within healthcare. So climate change is, sorry, just a sec. So climate change refers to this long-term shifts in temperature and weather patterns, as Gareth has pointed out. Such shifts can be natural due to changes in the sun's activity or large volcanic eruptions, but unfortunately, since the 1800s, it's human activity that's been the main driver of climate change, primarily due to the burning of fossil fuels like coal, oil, and gas. Unfortunately, the situation's got much worse, with 9 out of the 10 hottest years on record occurring in the last decade. And sadly, for us in the UK, that's meant that more than 2,500 people were killed by heat waves just across the UK itself. There will be an increase in the intensity of heat waves, more frequent storms and flooding, and increased spread of infectious diseases as a consequence of this, if we do nothing about it at all. And that climate crisis isn't just going to affect the planet, but unfortunately, this is going to affect us in healthcare as well. And this is quote from Tedros Ghebreyesus, the Director General of the World Health Organization, tweeting out to say how important this issue is. The Lancet looked into this and they set up two commissions. The first one thought tackling climate change was possibly a risk for healthcare and what that might mean because of all these changes that are going on. But then further down the line, they did another commission, and this time they saw it more as an opportunity rather than a risk, and start to think about what kind of changes could we make that could make a difference for the planet, but ourselves as well, and the population at large. Climate change isn't just undermining not just our planet, but it's also people everywhere, as I've said. And that's really in terms of things like the toxic air pollution, as Gareth has pointed out, diminishing food security, higher risks of infectious diseases, extreme heat and drought, floods, and a lot more. And as a consequence of that, not only is it affecting our health, but our ability to grow food, for housing, feeling safe, and being able to continue the work that we're doing. And let's not forget that it's not just about us moving around, but when wars take place, wherever they are in the world, it doesn't just affect the people there. And I am calling for a ceasefire on any wars that are happening where innocent men, women, children are being killed. But the impact is massive. And this was a paper came from the States that between 2001 and 2017, the US military emitted 1.2 billion metric tons of green gases, more than 400 million of which was due to the war itself. And the largest proportion of that was due to the fuel consumption from military jets. There's a huge thing that we on the planet can do to apply pressure to try and stop wars that shouldn't take place, because it affects us all. It's not just those people there. But if I come back to what's going on in the NHS, in the National Health Service here in the UK, as an organisation, we can contribute to 5% of the UK's total carbon emissions. And to put that into context, about 5.9% of total emissions are from the air industry itself. Research has shown that 92% of the general public believe it's important for the health system to work in a more sustainable way. Over a third of people agreed, even if it costs more money, and a quarter felt it should be a top priority. NHS staff also were overwhelmingly keen to back this action. And a YouGov survey conducted in August 21 found that 87% of NHS staff supported the NHS and its net zero ambitions. The findings of this research, which surveyed the views of over 2,500 people, showed that almost all staff asked believe that it's important for the health and care system to support the environment itself. And in general practice or family medicine, most carbon emissions, about 60%, are from clinical work. Prescribing is by far the largest contributor to these clinical emissions, and particularly these metered dose inhalers, the sort of inhalers that you use that have propellants, have 3,000 more potent than greenhouse gases themselves, such as CO2. So what is the NHS planning on doing? Its vision is to deliver the world's first net zero health service and respond to climate change, improving health now and for future generations. The NHS long-term plan set out a commitment to deliver care in new ways for the 21st century, and this must include a focus on reducing carbon emissions and will involve using environmental impact as an additional factor when designing care. About 25% of emissions are thought to be due to medicines, about 2% of which are because of anesthetic gases and nitrous oxide, and about 3% because of inhalers, as I've pointed out earlier. But there's also about reducing waste, ensuring that the right medicines are available for patients, and enabling shared information decision-making when deciding whether someone starts the medicines or not. The NHS estate is thought to contribute about 15% of the total carbon emissions. And then travel and transport. Approximately 3.5% of all road travel in England relates to patients, visitors, staff, and suppliers to the NHS, and contributes about 14% of the system's total emissions. The supply chain, for non-medicine supply chain, makes up about 42% of the NHS carbon footprint plus. There's two parts to it. There's the NHS carbon footprint and the NHS carbon footprint plus. And the plans are that for the emissions we control directly, the NHS carbon footprint, we'll reach net zero by 2040 with an ambition to reach an 80% reduction by 2028. And for the emissions we can influence that are not directly ours, we'll reach net zero by 2045 with an ambition to reach an 80% reduction by 2036. These are ambitious targets, but you can imagine the impact that could have for people. And if we can learn from this and share it with the rest of the world, then everybody else would benefit from it as well. Food and nutrition contributes about 6% of the carbon footprint. And then finally, thinking about not just what contributes to it, but how do we adapt to a changing environment? What else can we do? So moving towards more remote monitoring, using more efficient cooling systems, and perhaps in the short term, using air conditioning units as the country gets hotter and hotter. But that's a short-term solution, with a longer-term one looking at as temperatures drop. And finally, thinking about supporting delivery through research and innovation, finance, digital services, and data analytics. In terms of general practice, there are non-clinical things that we can do, including thinking about the carbon footprint for each building that we have, thinking about the travel and transport, both for staff and patients, having greener buildings, thinking about where we're procuring services from, and also thinking about how we can reduce waste. And as far as clinical things are concerned, it's thinking about when we're prescribing and we're de-prescribing and stop prescribing things, trying to stop overdiagnosis and trying to practice more patient-centered medicine, thinking about active travel, promoting healthy living, of course, trying to change our inhalers to things that are more safer, and actually thinking about nature and health. So what have we done as a GP practice to contribute to what's going on at a global level? Well, locally, within our locality, we had a big meeting where all the GPs and practice managers came together to discuss why global warming matters and the impact that the NHS has on that. We're constantly thinking about how we can switch lights off, close doors. We've changed our light bulbs to energy-saving LED lights. We recycle our paper as much as we can. We've moved towards remote working. Printers have been taken out of the clinical room, so we have a centralized place where we print paper, and that's really to try and help us to stop printing as much paper as possible and save some trees and ink as well. And in fact, 3 of our partners out of 8 of us have now got electric cars or have bought electric cars with plans for more of us buying electric cars and moving towards electric rather than using fossil fuels. And then in terms of clinical things, we've bought electric bicycles for our staff to use for home visits that might be nearby. We're promoting healthy living and well-being. We're encouraging patients and staff to cut down the amount of carbohydrate they take, changing our inhalers from meter-dose inhalers to dry powder inhalers, responsibly sharing and reducing unnecessary wastage with our patients as well. And I've been a big champion for patients accessing their medical records and understanding them through this partnership of trust, so they get a better understanding of their healthcare needs to hopefully help them to keep well and stop becoming unwell. And encouraging patients to go online to book appointments, contact the practice, order drugs, view their records online, including consultation test results, rather than driving to the surgery, coming to the front desk and then trying to speak to somebody at the surgery itself, see if they can try and manage their health in their own home. And in terms of how many of our patients can do this, this is our latest data. We've got 12,777 patients. 81% of them have got access to their medical records. And that's just showing data that shows across different conditions, including asthma, diabetes, pregnancy, learning disability, and even Bengali patients who don't speak English. If we put the right level of support in there, they will be able to do this. And so finally, this is me in the consulting room with Paul, our vice chair of our PPG, and you can see us both happy talking. We're not talking about not wanting to see each other, but you can see he's got a mobile phone in his hand, and maybe he could use that to manage his care. And finally, weekdays I'm in my surgery seeing patients, but at weekends I go walking. We've set up South Manchester Muslim Walking Group, and this was last Saturday, where we went for a walk for about 2 or 3 miles. It's a great way of coming together, meeting with each other, talking to each other, and improving our health and well-being. Thank you very much.
Thanks a million, Amir. That was fantastic. Just such a great oversight of how general practice and now actually change is actually happening on the ground. let me just bring in Joseph, who's just joined us from the Great Green Wall of Africa. And maybe, Joseph, you could just set the scene in terms of COP and what we can expect from the Great Green Wall of Africa. You're on mute.
Okay. Can you hear me now?
Go ahead.
Can you hear me now? Okay. Excellent. So thank you very much. I really appreciate it, Gareth, and that was an awesome presentation there. And I was listening to that, and I kind of see how this aligns perfectly with agenda for COP 2020 for COP28. Quite honestly, when you really think about what's happening around the world and what the challenges, the impact on the local communities and the indigenous people, particularly in Africa, where GGWoA, the foundation that I represent, is really focused on from a sustainable development standpoint. It's a huge issue happening there from healthcare standpoint. When you think about the Sahel, where the Great Green Wall project is currently being born and where it's currently going on, there's huge amount of issues from that is being caused and displacement of people there. Not to mention the number of kids that are there without healthcare. For them and even their parents. So this is really big. And of course, when we talk about climate, we always have to talk about health, because they go hand in hand. Now, at the COP28 this year, of course, we have a huge opportunity there. We've been given a pavilion there. And of course, what we're going to do is to host several events. And one of the key events that we're going to be having is this event on health. And that's the Healthy People Equals Healthy Planet. And we're co-hosting this event with the COP28 presidency. So we're going to be talking about a lot of things which have been mentioned here today, and particularly trying to figure out what sort of thing do we have to do over the next 7 years before the 2030 target, and see how we can mobilize resources, mobilize technical support and capacity building to make sure that we're able to get to that end goal and be able to achieve all the desired outcome that have all been laid out for COP. But of course, we're starting out from December 1st of December, where we're starting with a women event. And then, of course, that takes us all the way to the 10th of December, where we're going to be talking about some of the action plans that we're laying out from a GGW perspective. And when I say GGW, I mean the Great Green Wall Initiative, which is, again, part of this reforestation and land restoration project, and of course also decarbonization effort built within that as well. So we are going to be talking about that mostly on the 10th, what our action plan is for the next 7 years until we hit the target of 2030. But please, I welcome everyone to join us. There's a lot of things. And we want folks on this call to be part of that, because again, I think it takes a village to raise a child, and particularly in this case, it takes the whole continent plus, global hands on the table to really get these issues resolved. But I can go into more details about the programs, but the health is one of the key things that we will be hosting at the COP this year.
No, I appreciate that. And I think now we can transition into some of the solutions, and everyone here is a key stakeholder, a key partner. And I'll bring in James Sanderson from the Global Social Prescribing Alliance. And James, perhaps you can set the scene for the path that we've been on. Myself and James have been working on this for the last couple of years, but perhaps you can put it in the context of the opportunities to work with the African Union, for example, and wider stakeholders. We are also engaged with the Commonwealth, but James, over to you.
Thank you, Gareth, and thank you to Amir and Joseph as well. It was great to hear from you today. So I want to talk a little bit about social prescribing and why I think social prescribing is important for both global health, but also a great way that we can really bring together health and the environment as a key issue. One of the things that we've learned, Gareth and I, through the development of the Global Social Prescribing Alliance is just how unified the world is with the major health challenges and environmental challenges that we face. And one of the things that I don't think we do often enough is get the opportunity to share the expertise from around the world in how we can face these, because we are going to be much stronger together across various divides if we begin to work in partnership and collaboration. And this gives us a great opportunity, this conversation and further work to do just that. One of the things that's really clear is that all areas of the world, whether they have a very developed health economy or they are just emerging with health structures in place, some of the challenges are quite universal. The basics of health, what makes us healthy as human beings, we know very clearly, access to clean water and sanitation, which unfortunately some people across the world still do not have, is a key factor in our health and well-being. Access to medications, basic medications, vaccinations, some of the things that we take for granted in some countries, unfortunately, are not spread across the world yet. We also have issues about the environment around us, though. Whilst our DNA, the medication access that we have, and other things influence our health and well-being, the environment around us is one of the biggest factors in determining how healthy we are going to be. In this country that I'm talking from at the moment, in England, we have a 10 to 15 year gap in life expectancy between those living in the richest and those living in the poorest areas of society. And what we find is that in most developed health economies across the world, we find that gap is equally similar. We also find that not only do people have lower life expectancy in poorest areas of society, they also will experiencing more years of unhealthy living as well. And many of those factors come down to the environment around them. If you think about the ways in which we can stay healthy, we have lots of challenges with our health and well-being, but actually fundamental to human health and well-being are the relationships that we have with people, having purpose in life, having activities, and having good environment. And actually, where social prescribing comes in, it looks across all of those factors. Social prescribing effectively is a way of looking at health holistically, looking at an individual's life, looking at the skills, the knowledge and confidence that they have, looking at the assets that they have around them, and whether or not those assets are few or plentiful. We all can bring assets to our own lives. So what assets are available to the individual in themselves, in their knowledge, their skills, in their families, in their communities around them? And how can we use those assets in order to influence how healthy that individual will be? And how can we use those assets to really improve that individual's health and enable them to achieve the outcomes that they're looking for? Well, there are a number of ways that we're doing that. And through social prescribing, what we believe is that connecting people to various opportunities in their community, whether that's through arts and cultural activities, whether that's through knowledge and learning opportunities, whether that's through sports and exercise, or whether that's through the natural environment, we can really influence people's health. So when we think about the environment then, why is being part of nature, why is having a good environment good for our health? We've heard some of the stats from Gareth and Amir around some of the real challenges around the environment and the impact that has on our health. So why is the environment good for our health? Well, we know the evidence shows that being out in nature can reduce our blood pressure. It can support with the management of cardiovascular or respiratory illness. It can help being in the environment with cognitive decline. It's also a key factor in supporting people to manage diabetes and deal with obesity. It can reduce social isolation and loneliness, which we know are detrimental to our health. Social isolation and loneliness can be as harmful as smoking 20 cigarettes a day. And actually, when we talk about being part of nature, experiencing nature, experiencing the environment, the evidence actually shows that just 2 hours a week, a dose of nature, good quality nature, just 2 hours a week, can really massively influence our health. So being part of nature, and one of the things that we've been working on for many years is the concept of green prescribing, green social prescribing. Getting people connected to the natural environment, whether that's through volunteering, whether that's through walking, whether that's through conservation work, whether that's through just, getting out and about in your local area, is really important for health. Blue social prescribing is also a factor as well. The opportunity of swimming, the opportunity of experiencing water. Now, one of the things that I know is really challenging is that these opportunities are not universal. Some people, unfortunately, do not have access to green spaces. Some people do not have access to the type of environment that will help influence their health. But if we can create those opportunities for people to connect with health, with the environment, and connect with their communities, we can create better circumstances for good health and well-being. The Global Social Prescribing Alliance is working across the world with many organisations, looking at ways of creating partnerships that base their health innovation on connecting people to psychosocial support in the community. This isn't about challenging medicine and the opportunities that we have through biomedical changes and developments in health. Biomedicine will still play a really strong part. But if we can embrace opportunities to keep people well by engaging them with their environment and their communities, we can create the circumstances for global health improvements that perhaps are much more cost effective for economies right across the world. Thank you, Gareth.
Thanks, James. Fantastic insight into the Global Social Prescribing Alliance and the work that we've been, myself and James have been working with many colleagues around the world. This is a collective effort, as he said, and we started a number of years ago. Let me now just focus on Africa and Daniel's proposition. Daniel, it's a pleasure. I know you're joining us from Geneva. Perhaps you do a short introduction for those who, and then I'll bring up your presentation as well. You're on mute at the moment, Daniel.
Thank you very much, Gareth. I'm Daniel Itiale. I have been in public health for the past 40 years, and the 25 of which was within WHO, in charge of all the 54 countries of Africa, helping with the fight against blindness and poverty. It's a real pleasure for me to be part of this presentation, and I hope I will show you, on one hand, why we cannot continue to do what is going on right now, the way we do it, including myself having done it in the past, and why we need to rethink completely the healthcare service delivery in sub-Saharan Africa. Next. So why do we need a new model of care? And the answers are there, and I'm going to show you some evidence because the challenges we face are so many and diverse, and there's no quick fix, even over many years. And also because the situation is quickly worsening. And with all that is being said on the climate change, it's only likely to get worse. But at the same time, we also have the opportunity, because we cannot do otherwise, to reinvent ourselves and to suggest some other ways of doing things. Next. Here, I'm pulling together some of the available evidence that we have, whether in terms of burden of diseases or in terms of mother and child health. Everything that you see in red is the projected increase in terms of death of diseases that we know, like cardiovascular diseases, cancer, and so forth, and diabetes, and so forth and so forth. And on the other side, you have what happens currently with mothers and newborn. Africa, sub-Saharan Africa, has the highest rate of both maternal and neonatal mortality rates. And it doesn't stop there. Those who survive, up to 40% of them, are such severely malnourished that their future is completely compromised, because we know severe malnutrition means that that child will never be an engineer, a doctor, or a teacher. Next, please. And it's not just about the burden. It's also about what is available out there in terms of facilities. Everything that you see, I'm sorry that the presentation, I don't know why it's showing that way, a bit broken down. But what I'm trying to show in green is what is available in terms of health facilities, and in red, what is not there. And on the other side, you have what we have in terms of health workers, whether it's community health workers, midwives, specialists, or doctors. The one thing that is quite striking there is that most of those things are not yet there. The health facilities are not ready for the challenge that we are facing, and the health workforce that is available is not just there. And this may continue like that for decades unless we start looking at things differently. Next, please. And again, as you look at things are only likely to get worse, because it is projected that by 2050, we would be in sub-Saharan Africa short of 3 million health workers. And this situation is even has gotten worse again, because since the pandemic, there have been a demand from the north. Countries like France, Germany, Canada, who need more doctors from Africa. And so we are already so short, and so things are only likely to get worse. But it's not just about the shortages in quality, in quantity. It's also the shortages in quality. And that's what I'm trying to show on the table on the right, because as you can see, whether it's healthcare, primary healthcare, maternal and child health, malaria and diagnosis and control, emergency care, surgery, whatever you take there, everything you see on the right, it means that it's inadequate. So we are short of staff, and at the same time, the services are not on par with what is expected. Next, please. Now, I don't know how clearly you can say this, but what I'm trying to show here is what WHO calls a normal healthcare delivery system. And it's composed of three levels. You have the primary levels, which is closer to the community. You have the secondary level, and then you have the tertiary level. When everything works well in a normal system, the primary and the secondary level are capable of dealing and handling all the health problems coming from the community. And the tertiary level is there for referrals and for more complicated, more specialized stuff. Next, please. The problem we have is the opposite. We have what WHO calls an inverted pyramid of healthcare, a complete disaster when it comes to healthcare delivery. Because what it means is that the primary service, the primary level is not functional, the secondary level is not functional, and people may have sometimes to travel up to 1,000 kilometers or more to go and seek services where they can find them. And of course, what that means is that the most vulnerable will never be able to do that. And as a result, even as I'm talking today, there are still 52% of the population in Sub-Saharan Africa who don't have access to healthcare. Completely unacceptable, and that's why we can't just continue to do things the way we have been doing in the past. Next, please. So then the question comes, given all that I've just mentioned, is there any way out? And the answer to that question is no, if we continue business as usual, but a resounding yes if we seize this moment and start thinking more creatively and more strategically. So I have 2-3 more slides to show you of the things that we can start doing beginning from today. So the first set of things that we can start doing from now onwards is to build and equip, supply and maintain all new hospitals sustainably. What does that mean? It will mean, among other things, that ensure that there's continuity in terms of power supply and continuity in terms of water supply. And these things are possible through solar energy, for instance. More and more hospitals in the future should be solar powered. It may be a little expensive at the beginning, but it ensures continuity of services. The second set of things that we can start doing is to make sure that henceforth, the health workers that we train are actually trained for the jobs that awaits them, not just for certificates, because that's most of the training now focus too much on certificates. And there are some specialties, for instance, where up to 80-90% of the specialists can't actually do the things that are expected of them as specialists, but they have a certificate. So it only compounds everything that we're talking. Next, please. So we can, despite the fact that we cannot change this inverted pyramid overnight, there are things that we can start doing right now to strengthen the services. One is that we can look at all the existing healthcare workers, and we have just shown you that many of them are not adequately trained. So we can give them a second chance of training, but that would also mean training the trainers in more modern techniques of education. We can, and one way to do it very quickly and effectively and safely is to establish simulation training centers. They may be expensive initially, but I can assure you that they would help us ensure that people can be trained quickly, effectively, not on patients, but on simulators that have been designed like patients. And the advantage of simulators is also that they can learn to work as a team, which is something that is not happening. And the last set of things we can do is in bridging the gaps, is to take every opportunity to introduce and promote healthy lifestyles and wellness, because there are many chronic diseases that may take up to 30 years to manifest themselves. But yet we do have, there are things that can be done before the disease manifests itself. And on this list, I have maybe one more thing that I can mention is 2 things. One is to look at how we can introduce leadership training, especially among those who are in leadership positions, because that would be very helpful for them. And lastly, how we can engage the communities, not just as beneficiaries of care, but as co-partners in healthcare delivery. So my conclusion is that in the face of all that we have in front of us, there's just no way that we can continue as business as usual. But we need to reinvent ourselves, and our organization is willing and ready to help push in that direction. Thank you very much.
Thanks very much, Daniel. A fantastic insight. I think what was startling to me was just the sheer lack of medical professionals in Africa at the moment, which is just astounding. And also the future demand that we're well aware of. I think we can all speak, and this is just not an African problem, but this is a global health problem. I'm delighted to bring in my colleague Harris, who I've been working closely with on a number of brain health initiatives. Harris, welcome, and delighted to hear from you. The floor is yours.
Awesome. Wonderful. Thank you so much. And just let me share screen.
Yeah.
And tell me.
You might have a little bit of feedback, just so that you're aware of.
Right. Is it better now, Gareth?
It's still a bit crackly. I'll add your presentation, which you can see.
Okay.
There seems to be a bit of feedback, unfortunately.
Okay. I don't know what to do. I can get my AirPods out and see if that works, or I can push on.
Yeah. Thanks.
AirPods?
Definitely, it's your mic, I think. So if you pop on your AirPods, that'd be great.
Okay.
So just while we're waiting for Harris there, I think there was a fascinating insight into some of the issues and challenges that we face, and this that Daniel went through. But this is actually, a problem globally, and in terms of health infrastructure, new models of care. I think James gave a great insight into the Global Social Prescribing Alliance and social prescribing and what's been adopted in the UK. There's many lessons that we can learn from. And I think, key that we transfer those lessons to lower middle income countries so that there's cost savings made. So we're just waiting on Harris to come back in with this on the iPad, but on the let me see. Go ahead, Harris. I think still.
Okay. Can you hear me now?
Yeah, we can hear you fine. Perhaps just carry on. There is a little bit of crackling, but I think we'll just have to persevere.
Okay. All right. Okay. Well, let me just thank you, Gareth, and to all the other speakers for allowing me to make an intervention today. I'll today talk about something a little bit different. Gareth, can you still hear me? Just checking.
Yeah, I can hear you. I think there's just a slight. I don't know, Harris. Do you want to just try and log back out, or maybe come back in on your phone? Perhaps you could leave on the shared screen.
Actually, now I think it's working now. My AirPods are working. Has it gone away?
No. Can everyone else hear that? Yeah, I think. Go ahead. Just go ahead.
Okay. It's a bit better. Okay. So today I'll talk about the brain relevant to this discussion. And then I'm also going to take an angle of economic policy as well. So I hope that what I'm bringing today is complementary to the other speakers. I'm going to be talking about the environmental determinants of brain capital. So brain capital is a new economic asset that colleagues and I are proposing should be critical to the way that we think about nation states and how to govern nation states and how to look after the population of nation states. Brain capital is a stock of the brain health of a citizenry across the lifespan. And it's also a stock of the brain skills of the citizenry across the lifespan. Brain skills are skills which are paramount in the modern economy and in the future economy as well, like creativity, adaptability, resilience. So brain capital is, even though I'm a physician, I'm trying to come in at a systems level and propose to sort of hack economic structures, if you will, and propose that brain capital is really essential. And so this is brain capital across the lifespan. We all sit somewhere on this spectrum. We all have family on this spectrum. We all see patients on this spectrum. We all are aware of things in green that are positive. some presented, such as social prescribing or social engagement. And we're also aware of things that are orange or negative for brain capital and harmful to the brain. And of course, we know that relevant to the environmental determinants, there are a number of things that are harmful to our brains. We have environmental disasters, which cause tremendous stress and pressure on people, trauma. We have mass migration, which is creating issues of food insecurity and water insecurity for folks. Air pollution is a major issue, has already been mentioned today. Harmful exposures, you can see here through things like chemicals and nanoplastics. Plastics are now breaking down from our, what we use plastics in day-to-day life. They're breaking down into micro and nanoparticles, and they're found at the top of Mount Everest and on the bottom of the deepest depths of the ocean. And they're also, because they're nano size, they're getting into our bodies and in particular into our brains. And it's a new area of science to understand exactly what this is doing. It could be something like air pollution or perhaps even worse. So we need to do a lot of science on that. Of course, then lack of exposure to blue and green space is also something that's potentially harmful to us. And then finally, loss of microbes and microbial diversity. Another interesting piece to say that looking beyond health policy, that's a lot of what I do now. Is I respect that many people are focused in health policy, and I encourage them, and that they can do it better than me. So I'm trying to think asymmetrically and think about how can we take neuroscience, mental health, and neurology outside of health policy to see if we can get some advantages for our field that we care about in the brain and mind of people. Here's an example where we've taken aim at the industrialized food system and suggest that that is undermining brain capital. The industrialized food system has been helpful in history for getting long life food to all corners of the planet. So it's been previously a positive. But now we argue that it's most likely a net negative. Ultra processed foods, in particular, high sugar, high salt, high preservative foods, are shown to be harmful to our health in many ways, but in particularly correlated with depression and anxiety. And then, of course, toxins in food production are not healthy either. And then we also see that the commercial milk formula industry is really trying to influence women away from breastfeeding and towards using commercial milk formula. So the interesting thing also about the industrialized food system is it's responsible for over half of the greenhouse gas emissions in the planet. So it's not just harmful to us and our brains, it's also harmful to the planet. So we have written a large paper about how policy recommendations to try to address these issues, and it can be found in that link below there through my and also through the Baker Institute for Public Policy where I work. So what is the solution then to all these environmental determinants of brain capital, the way the environment is undermining our ability to think and feel and flourish in life? Green brain capital is the model that we've developed. We think about the importance of building adaptability for people. So how do we reform education and health systems to optimize adaptability for people that need to navigate the very complex world where we're going to have more climate shocks? How do we allow people to be more creative so that they can invent solutions to solve social and ecological problems? Teaching people green skills is important. Of course, this all happens on the foundation of brain health. If you're not brain healthy, it's very hard for you to get the best skills and engagement in education in the workforce. And digital literacy, of course, so that you can understand what is good information on the internet versus mis or disinformation. There's obviously a lot of climate mis and disinformation that's creating division and discord in the community. And then ecological intelligence. Are you learning how to make the right kind of decisions in what you use, what you buy day to day? So this is our green brain capital model that we've published on in a couple of different outlets. So if anyone's interested to read more, you can check these out. We're in the process of refining this green brain capital model. It was first written as a white paper or a scoping review. Colleagues, including Mohammed Salama at the American University of Cairo, are going through a Delphi process now to refine this model. If anyone's interested, just feel free to send me an email or connect with me on Twitter or LinkedIn. that Delphi process is underway. And on the right-hand side, we have already published a global brain capital dashboard looking at the determinants of brain capital, brain health, and brain skills. We're going to add much more on the environmental determinants, and we'll be launching that at COP28. And so the final point is to say that the SDG progress there's been some progress, but it's now arguably inadequate. We're not seeing as much progress as we wish. And so one of the things we'll also be presenting at COP28 is our model for how brain capital can unlock further SDG progress by talking about the linkages of brain capital with each of the SDGs and how this is a bidirectional linkage, and how we can develop hopefully positive feedback loops. If we invest in brain capital, we get more SDG progress. And if we invest in SDGs, we get more brain capital progress as well. And I think the final point to say, particularly on the financing side, we're very interested. I'm very keen to hear the next couple of speakers talking about financial innovation, because really in the brain capital world, we think that public and private activity is important, and unlocking financial innovation is critical as well. So very interested to hear what speakers say. So thank you very much, and I'll see you at COP28 or somewhere online or at a conference one day. Thanks, Gareth.
Thanks, Harris. That's fantastic. And what we'll do is I'll combine all the presentations and the links for the speakers. I'll pop them on the chat so that people can reach out and get in touch. Next up, I'm going to just bring in Nisaa, who's going to just bring in some of the ESG and the link between healthcare and impact investment. Nisaa and I have been working on this for a number of years. Nisaa, the floor is yours, particularly with a focus, I think, as well on emerging markets, and there's huge opportunities.
Thank you so much, Gareth, and I appreciate you having me as a speaker. I love the ability to be here and make an intervention, and I do really align to a lot of what the speakers have said today. By way of background, I'm an attorney. I did benchmarking of private equity deals across emerging markets and have started Impact for SDGs, which really aligns portfolios to the Sustainable Development Goals. And my kind of thesis right now is that we see emerging healthcare problems which really are going to have systemic climate issues. And when we look at the environmental, social, and governance angle, their whole thesis is that with ESG investing, it is a negative screen on what not to do. And now there will be a particular focus on healthcare and climate-related industries. So there is now this intricable link between healthcare and climate change, which really underscores us to explore this niche. And by way of background, we did have the Millennium Development Goals. So when we talk about the impact space and development finance institutions, they did really benchmark the world's to-do list through the UN, through the Millennium Development Goals. In 2015, the world came together and we did have two big things that happened. One was the Sustainable Development Goals, which were a list of 17, as well as the Paris Agreement in parallel happened. And this year, at COP28, it is the global stock take. So it is really like we are looking through a lens now to see how did we do in relation to this. And I just wanted to also discuss, as Gareth and I have mentioned, there is this vertical where we are talking about the impact investing space, where climate cannot really be seen without the human health argument. And when we see the ecosystem right now, what I view is when you look at post 9/11 legislation and the compliance standpoint, we're now seeing the same kind of compliance around climate. Climate really is an investment risk, and it also showcases that if we invest in climate, we're also protecting public health through multiple of mechanisms. We can guard against extreme health weather, precipitation, as well as air pollution, and really safeguard infrastructure aspects of our healthcare communities and vulnerable regions. I do resonate with some of my colleagues who mentioned there is a systemic issue on the brain drain. So obviously investing in these infrastructure and verticals at the outset will also outperform the market. I also believe that the convergence of health also presents notable opportunities in relation to leapfrogging. So specifically in emerging markets, we see something called leapfrogging. For instance, in East Africa, we had something called M-Pesa. We went from no phones to mobile banking. And what we really see here is telehealth and digital healthcare will really enable a lot of these outcomes to really outperform their market. It's a massive investment opportunity. And it also will enable us, especially with AI technology specifically, to safeguard against human health issues, as well as for climate and climate farming, for example. We are able to look at specific irrigation mechanisms, we're looking at outcomes, and we're also able to model a lot of these going forward. So with the emergence of this, we're really encouraging also a social impact and resilience vertical. So when we talk about ESG, often ESG investing is looked at a negative screen. What do we not do? We safeguard on a risk around environmental, social, and governance. A lot of ESG does fall without a strong governance lens. So we see a lot of deal flow now adding the G into the ESG. And when we look at climate and health, it does marry with the same vernacular now, because we do see social impact and resilience in the S really coming out as a vertical. So in conclusion, I do feel this health and climate wellness is going to be a robust vertical that people invest in. It will look to the ESG space on a negative screening. It will outperform the market, and there will be several verticals for others to invest in. I appreciate that. We're almost at the clock. So Gareth, I will hand it over to my next speaker. Yeah. But Gareth and I are also writing just a short piece that you can read about after this panel. But very grateful to be here, and thank you for the time.
Thanks, Nisaa. And I think now what we need is to look at the vehicles, which brings us nicely into Victoria and the work that we've been doing with Orora. Victoria, the floor is yours. I'll bring up your slides as well, just so that people can see. There you go. The floor is yours, Victoria.
Brilliant. Thank you, Gareth. And it's really an inspirational talk so far. And I think my journey into this space began in the pandemic. I'm a lawyer by background, and I've been inside banks helping them think about digital transformation, which has classically been how can we do things cheaper, faster, quicker, and make more money. And now I think there is a realization of how do we distribute money, and how do we get money to make the change and the transition that we need to see. So if we go to the next slide, Gareth, what we've really been thinking about in Orora after we developed our aid distribution tokenized wallet and programmable money that we leveraged throughout the pandemic to support people that were unbanked, and that ultimately led to us presenting this to the UK government and to the OECD about a future distribution model for aid, and then working with Bank of International Settlements and the Bank of England to think about how, if we will develop central digital banking currencies, how we could use these new forms of money to be able to do things good. And this has ultimately led us to create Carina, which is our impact banking as a service platform. And I'm really glad that Nisaa mentioned M-Pesa, because this is really about what mobile money can do. You can stop the money getting lost. You can create the story of helping the people get banked, and then that means helping people get access to healthcare. That means helping build hospitals. That means helping pay doctors, and it means helping distribute grants so people can have the education journeys that needs them to become the huge amounts of healthcare professionals that we've earned. And this is about getting money to flow and point it to where we need, which is the achievement of these SDG goals. There is a huge funding gap. There isn't a loss of money. There isn't money that is not there. It needs to now be pointed in the right direction. So that's with our Orora resilience instruments, what we want to do. So if you go to the next slide, Gareth, what we're talking about here is creating a new formula for money and how we can get finance, society, and environment to come together through the technology to be able to transfer and have the impact. So we can get that inclusive support. So what we've come up with our resilience instruments, Gareth, if you go to the next one, is looking on a flavor of how we classically fund and finance whenever a climate catastrophe happens. There has been something called catastrophe bonds that have existed for a long time. They're very paper-based, they're very expensive. Quite often, it's very hard for those instruments to be issued and funders to actually see what the impact of their money is. So what we're doing with our digital platform is making that really simple, making it cheaper, faster, quicker, but better, more compliant, better governance. So using the benefit of programmable money so you can really see where this flows. So we look at geohazards that are happening more frequently, whether this is in East Africa or the Caribbean, or even in the UK, as we've seen with the huge amounts of floods that we've had. We can point these instruments at dealing with these regional changes that we're seeing and making sure that resilience plans and that money is going to dealing with that change and transition that we need to make in our economies that we've heard everybody so eloquently talk about. So if we go to the next slide, Gareth. So to give you a worked example, so to speak. So we've got a volcano. The volcano is seen to have early warning systems around it. And through that geological data, that satellite data, we can now create parametric triggers that go into our financial instruments and work in our systems that we have in place in our financial economy. When the changes in that environment, the money that is within those instruments is instantly pulled and be able to distribute into wallets that are pre-programmed, whether that be with the local authorities or NGOs or charities or certain businesses that are involved in those resilience plans to make sure money is moving to where it needs to be. Because this is often what happens. Generally with one of these climate events or certain droughts or other instances, it takes years for GDP to recover. When you look at Morocco, for example, and the recent earthquake that we've had there is an £11.7 billion worth of financial money that is required to restore it, to get back to the place where it was. We need that money to be there in the system. That money can be working and earning and actually can be investing in other companies and developing systems. And that's what we want to show. And through our data stories that we can share through our platform, we can give that confidence to the market, to the pension funds, to the private family offices, that this is actually going where it should be. And this isn't just all paper and money that's flowing through the existing systems. Because what we need is to enable people to have the confidence and the trust that this money that we need to pump into the transition to enable the achievement of the SDGs is actually really happening. All too often, people don't donate their money. They don't put their confidence that their taxes are going into these spaces because they don't see this actually happening. They think the money is going into the ether, or they hear the negative stories about fraud and corruption. With the financial technology we have now through programmable and digital assets, this is something that we can manage. We can actually enable compliance. We can enable money to get to where it needs to be. Even in emerging economies, this can really work, and it actually can be hugely transformative. So we're working with WIS and with other partners and coming to COP to talk about the instruments that we want to bring together. So I think if you go to the final slide, because I'm conscious of time, Gareth, this is where we want to be. We want to ultimately have this end game of a beautiful cyclical solution that is sustainable. So money is flowing through the system and helping us develop the innovation, helping us put the systems in place that we really need to have a healthier, more sustainable economy for all, and that no one is left behind, and that we can build that, because that's what's really important. And that's what impact investments needs, to have that trust and confidence, and also be able to see the stories that, like we've heard from today, the transformation that can truly happen when money has those impact values built in. So that's me.
Thanks a million, Victoria. Fantastic to see the linkage between health and the banking sector. This is exactly what we're trying to do. Now, I want to bring in my good friend, Dr. Ron Daniels, who's stepped out of the King's Fund at the moment. Ron is going to talk about emerging threats, which is a serious issue for us. Myself and Ron have been working on this for a number of years, but I hope at COP we bring some sort of tangible solution. Ron, final word to you, and thanks for joining us today. Please give people an insight into the work you've been doing on a global scale as well, and the emerging threats that we face from the health sector's perspective, and how we can actually bring solutions to the table at COP.
Yeah, thanks so much, Gareth, and hello everyone, and thank you also to the King's Fund for giving me this wonderful room for this meeting. So I'm Ron. I'm an intensive care clinician by background from Birmingham in the UK. I founded a UK-based charity, the UK Sepsis Trust, just over a decade ago, and I now am one of the vice presidents of the Global Sepsis Alliance, which is a global charity registered in England and Wales, which has offices mapped to the WHO regional offices. So we offer solutions in sub-Saharan Africa, in Bangladesh, and in multiple countries facing significant challenges around the world. Why are we talking about AMR within this meeting? Well, firstly to say, we're not just talking about AMR or antimicrobial resistance. We're going to talk about infection, we're going to talk about sepsis, the final common pathway to death from most infectious diseases around the world, as well as how it interlinks with and interplays with climate change, which is a really interesting area. So in terms of the quanta here, Lord O'Neill estimated some years ago now that if we don't act concertedly internationally, then by the year 2050, we'll see an additional 10 million lives lost as a consequence of antimicrobial resistance by the year 2050. We now believe that that was highly optimistic. A couple of years ago, WHO released data that suggests that AMR is implicated in as many as 1.7 million lives lost around the world already. Now, antimicrobial resistance in and of itself does not claim lives. Infection that we cannot treat is what claims lives. And I've already alluded to the fact that sepsis is the final common pathway to death from most infectious diseases worldwide. Now, that's commonly bacterial infections, but it's also viral and parasitic infections, including infections such as SARS-CoV-2 infection and COVID-19, and including diseases like malaria. So sepsis is one of the biggest killers on our planet. It's responsible for 1 in 5 lives lost worldwide, according to the WHO, and disproportionately affected are children under 5 in resource-poor environments, accounting for almost 50% of those deaths. Now, in terms of the quanta, these are almost unfathomable. Sepsis right now is estimated to affect around 50 million people every year around the world, claiming 11 million lives. That's more lives than are claimed by cancer. Now, our public have a vague knowledge, a vague appreciation that there is something out there called antimicrobial resistance, but they haven't heard the real sticky message. They've heard that if we don't do something, then when they're 80 years old, they might not be able to safely have a hip replacement. And of course, to our children, that is an intangible message. The reality is that antimicrobial resistance is here right now. It's here today. It's here in my hospital. It's here in the hospital near you, wherever you are in the world. One of the most common bugs that causes one of the most common infections around the world is, in resource-rich countries, is E. coli. And I was talking to a microbiology colleague just earlier at the King's Fund, and he works out of a small city in the UK, a city called Leicester. It's got a population of around 1 million people. And he's got data that tell us that within that city, depending on where people live, which is obviously influenced by the socioeconomic status of the environment in which they live, together with the ethnic makeup of the population around, the resistance patterns of E. coli vary from as low as 15%, primarily in the more affluent areas, to as high as 40%, particularly in areas where there might be a lot of travel over to South Asia, as well as the presence of multi-generational households. So antimicrobial resistance is here now, and our public need to hear this message. This is something that might affect your loved one tomorrow, should they be admitted to hospital. I've mentioned that 10 million lives lost by 2050 is optimistic. I'm running out of antibiotics now. We have patients who come in who have infections that are sensitive only to a single agent. And when those agents stop working, we won't be able to treat sepsis. Now, this might sound a little bit sensationalist, but that will mean that everyone who develops sepsis will die. That won't mean 10 million lives lost by 2050. That will mean 49 million lives lost by 2050, which will start to shift the balance of human population from a position of growth to a position of decline. And Dame Sally Davies, who's done more than most people on the planet to raise governmental awareness of antimicrobial resistance, has recently stated in the Spectator magazine that antimicrobial resistance is a more immediate threat to human existence than climate change. Not diminishing climate change, of course, but AMR is here right now. How do these two interlink? Well, there's a lot of evidence, and it was just over a year ago that there was a significant publication that looked at all infectious diseases, and it suggested that 58% of them were negatively impacted by climate change. Why? Well, of course, climate change brings about the vectors of disease to change their patterns of migration, to change their spread, their geographical reach. And so we see an increase in conditions like the tick-borne disease, Lyme disease, which causes a form of sepsis. We see increases in the spread of the geographical reach of malaria. And during heat waves, even in high-income countries where these subtropical infections are less likely, we see increases in waterborne activities during heat waves, and that is known to increase gastroenteritis. It's known to increase the presence of bacterial infection. So we know that climate change negatively impacts on the majority of infectious diseases. But it's more than that. When we deliver a message to our public about anything, that message is going to be ineffective if they don't know what immediate steps they can take to address the problem. So we have to get better with our messaging to our public around antimicrobial resistance. The public need to know that this is a personal threat, that this is an immediate threat, but that there is something that they can do about it. And there's been a lot of talk about changing behavior, particularly around antibiotic-seeking behavior. There's been legislation in some areas of the world, for example, in Chennai in India, that prevents the sale of antimicrobials without a prescription. And of course, we welcome that, and that needs to be spread further. We've got incentivization programs for the development of new classes of antibiotics. And of course, the subscription model for antibiotics needs to be developed and rolled out to other areas. But what can our public do right now? Well, we can educate them that antibiotics won't treat viral disease. We can educate them around diagnostics and around what diagnostics are available and how they can access those diagnostics, so we can work out whether or not they need antimicrobials in a more timely fashion and hopefully prevent their illness spiraling to one of high acuity. But we can also educate them around the individual steps they can take related to the food chain, because the use of antimicrobials in intensive farming for infection prevention across an entire herd of animals, as well as the barbaric use of antimicrobials as growth promoters in intensive farming, is bringing antimicrobials into our food chain. We are consuming antibiotics when we choose to eat intensively farmed meat. And it's not just the meat. If you test the milk that is produced by cattle who are grazed on pastures from mixed farms, including intensive farming, then that also contains antibiotics. And there is good evidence now that antimicrobial resistance in animal pathogens can rapidly transfer through viral segments to pathogens that affect humans. So the message to our public here is clear. We need to reduce this consumer-led demand for intensively farmed meat. We need to get back to a situation where, for those who choose to consume meat, it is a luxury. We need to improve accessibility to higher quality meat that's bred with good animal husbandry. And by taking those small steps, members of our public and we as broader society can do what we can to combat antimicrobial resistance. Gareth, thank you for the opportunity. I do recognise that compared with my previous speakers, it's slightly off topic, but very good to see you.
No, it actually aligns very well, Ron. I think also from Daniel's perspective, and I hope Daniel's listening in there, the shortage of staff, when you talk about, lower middle income countries, and when we look at the Great Green Wall of Africa, we need the expertise, Ron, that you can bring and share the knowledge. I think the capacity building side is a huge opportunity. And then on the banking sector side, Victoria and I and yourself, we're talking about this global fund that we want to work on together. We can connect, and again with Nisaa and our colleagues here, everyone really, it's like a collective unit. This is a huge problem. We face enormous challenges in healthcare, not just with climate change, but in terms of our staffing, and we just don't have the capacity. So I think we have to look at this new model of care. Doing business as usual is not acceptable. Daniel put it in his presentation very well. We just cannot continue to do what we're doing. We have to change the way we look at delivering healthcare, but also the impact and the economic impact that has on our society. Nisaa will know, Victoria will know, and we're all told there's plenty of capital. And I really believe that through the health sector, we really can bridge a gap into the financial sector and work with the financial institutions around the world to deliver actually more profit, which can be reinvested back into local communities. That's what we want to try and do. That's the platform with the World Health Innovation. That's the model. The mission is to create new businesses that have social impact, that can generate value and reinvest back into the community. So I think we're on the cusp of a wave. I think that there is capital available. I think stay tuned for those who are joining us, join us on the journey. The more people that get engaged in this work, and that's the real challenge as well, post-COVID, is building the trust within the community. Amir spoke about the partnership of trust. I really do encourage anyone watching this to really look at the profiles of the people who've spoken today. Each and every one is passionate about change, about healthcare, and also about delivering positive change for our future. I'll just wrap it up just to say all the material, we'll share all the presentations from everyone online. And we'll post up a couple of maybe blogs and various things. We will take tangible action, though. I think that's the group of people here are people who do things. It's not just talk. And for investors who are out there, banking institutions who are watching this, the large institutional investors around the world, the family offices, please reach out to each and every individual that has been on this discussion today, and then come work with us, because we want to work with you. And we want to deliver new models of care. We want to deliver new economic models, and we don't want to leave anyone behind. So that's the final message from me. I just want to thank all the guests here today, the speakers. It's been a phenomenal discussion, and very much looking forward to working with everyone in the future. And at COP, we'll be making some serious announcements, and then watch this space. So thanks everyone for joining, and I'll end the stream. And I think we've got some final messages that we might be able to bring up. But yeah, that's